Just want to make sure, can everyone see the PowerPoint?
Yes. Yeah.
Okay. All right. So we're gonna get started. And can everyone hear me okay?
Yes.
All right. So the journal I found for today is the title is Can an Outpatient Exercise Program for Pregnancy-Related Pelvic Girdle Pain Improve Pain Function versus Education?
Ingrid, we are having a little bit of trouble hearing you. I don't know if you can get closer to your microphone.
Okay.
Okay, thank you.
Is that better?
Yeah, that sounds better right there.
Yeah.
Thank you.
Okay.
Thank you.
All right. Okay, so this is a pilot study, okay, and the design is with a longitudinal two-group repeated measure time series design. So what that means is pilot studies typically is a small study used to test, the research protocols or data collection. So basically anything they want to do before they do the actual big study. So typically the subjects will be a very low number. And then so for these studies, actually only 12 subjects. And so they do a randomized design. So it's a two randomized group. And then repeated measure means that the same outcome variable is repeatedly observed or measured over time in the same study subject. Okay. So the reason why I choose these is because like next month, I'm doing a big in-service regarding the pregnancy-related pelvic girdle pain. So while I'm doing research for my in-service, I found this is a newer study and I really like it because it has a really good designs, randomizing all the protocol and everything is very clear. And for the previous other studies I saw, for the earlier study, a lot of them, the definition of the pelvic girdle pain is loose or they don't have a good randomized. They can be more like observation, or they don't tell you very well about their exercise protocol. So that's why I chose this one. I think it's a really good design. And then just a little background about the pregnancy-related pelvic girdle pain is typically the pain is between the posterior iliac crest and the gluteal folds. And then the theory is it happens during pregnancy because there's increased pelvic laxity with diminished muscular activation and coordination of the deep core, and then from hormonal changes. And that's why they develop this kind of pain during pregnancy. And typically the pain will be with load transfer from the lower extremity to the pelvis, doing weight-bearing activities like standing up, walking, a lot of single leg positions, a lot of single leg activities will make the pain worse. And it happens quite often. It's quite the occurrence is quite high. In most research showing that it's between 56 to 70%, 72% of the pregnancy population. And then there's a 7 to 25% of that persists through postpartum. And the current evidence of exercise as intervention is inconclusive. So I think I kind of gone over this slide already of why I choose this one. Yeah, so I'm gonna go to the next one. So the aim for their study question is to first examine the effect of the target trunk-specific exercises as well as biomechanical and positioning education for the pregnancy-related pelvic girdle pain. And also they want to assess the feasibility of the involvement of women experiencing the pelvic girdle pain in an individualized exercise program and enhancing deep core activation and coordination through the course of pregnancy. And then they want to conduct a comparative analysis of pain levels and functional outcomes among women with the pelvic girdle pain. They want to put them into two distinct groups. Group 1 is exercise and education, and group 2 will be education alone. So with their patient recruitment, is like I say, it's only a pilot study, so they only have 12 subjects included. And then I think only 7 finished the whole study. And then in the very beginning, I think they sent out they send out question or they ask about 60 to 70 feet a woman. Their criteria is they have to be between 18 to 45 years old and then between 20 to 28 weeks of gestation at inclusion. And their criteria to determine whether if it's pelvic girdle pain is they have to at least have two out of three of the following. The first one is the self-reported pain between the posterior iliac crest and the gluteal folds. Second one is positive posterior pelvic pain provocation test. Third one will be a reproduction of pain with the active straight leg raise test. And if anyone is not familiar with those tests, it'll be included in my in-service. Okay.
Ingrid,
Yes.
Could the pain be going down the leg too, or like needed to be localized, kind of?
Okay. So with their study, it's more they want you to be more localized. And with the older definition, what I see is like typically they say, okay, if it's more like a pelvic girdle pain, it can be going down a little bit to posterior side, but it doesn't go below the knee. So this one really like try to different, because there's they can be two different pain, okay? And this one really try to just grab those pelvic girdle pain with like a more clear definition. A lot of previous studies will be kind of mixed with lower back pain, sciatica, and pelvic girdle pain all together.
Okay, so they're just trying to get pelvic girdle pain purely.
Yes.
Okay, thank you.
Okay, so this is just kind of how they randomize the allocation. So like I say, it's only 12 enrolled, and then 7 in the exercise and education, 5 in the education alone, and then there's some dropouts. So the one that 4 complete in the exercise and education group, and then 3 completed the education alone group. Okay, so their timeline looks like this. So again, they have an initial session, and then they have follow-up in 2 weeks, and then they have follow-up in a 4-week interval all the way until they give birth. And then they will have a postpartum phone call 6 to 8 weeks after birth. And then the education alone group, other than the initial session, all other things all the follow-up are conducted in phone calls. And then with the initial session, what they'll go over is education specifically cover like body mechanics for bending, lifting, sitting, sleeping postures, and then like best practice for activities of daily living and transitional, so more like how you transfer from supine to sit, sit to stand, those kind of things. With the exercise and education group, they will have the same education, the same body mechanics, everything, and then they will have specific exercises. I think Alicia also attached the exercise protocol or the program for the study. So they have 5 categories. So there's breathing, transverse abdominis, pelvic floor, hip extensors, and hip abductors. And they have specific exercises in that program. And those are what I listed. So how they do it is each subject is only doing one of the exercises in each category, depending on their ability and tolerance. And then with the exercise and education group, all the follow-up is conducted on site, except for the last phone call postpartum. And this is just kind of the flow that we went over already. Okay, so the outcome is measured at baseline and at each session. So what they use, the first one is really easy, just a pain scale. So they ask about current, best, and worst pain is on a 0 to 10 scale. And then the second one they use is the PGQ, so it's a pain and function questionnaire. So I also asked Alicia to attach that. So if you're not familiar, you should be able to get that out and look at the questions they ask. I put it on the slide, but I don't think anyone can read it on the slide. But basically, it's just ask about then how much problem they have, with like dress yourself, stand for less than 10 minutes, stand for more than 60 minutes, all those things that's pretty standard. And then I think it's very similar also to a lot of like lower extremity scales. All right, so with their outcome, so basically their outcome shows both exercise with education and exercise alone, education alone demonstrate a decrease in current pain over time, but there's no statistical difference between the two groups. And with the PGQ, also both groups demonstrate improvement in PGQ over time, but there's also no statistical difference between the two groups. These are the result graph. So on the left side, the blue one is the education and exercise, and then the red one is the education alone. So the top one is current pain, and then you can see like the middle one is a pain at best, and then pain at worst. You can see like both groups kind of have a trending downwards basically. And then the right side is the PGQ score. So then how this topic relates to our patient, again, we're developing a program for pregnant patients with pelvic girdle pain. So I think it is really important to keep in mind that even like when they only come in for their first visit and we go over the education, the body mechanics, and then have them understand why they have this pain and then what they can do with some better like posture, better transfer skills, they can make a difference in their pain and function. And then main objectives learned. So basically, with these studies show that both education and exercise can decrease pain and improve function with women who have pregnancy pelvic girdle pain through their pregnancy and postpartum. And then education alone can be an effective intervention, especially when coming to an on-site appointment is not easy or not feasible for the patients. And then also that with what they are discussing in there, what a lot of people, their subject, their complaint is it's difficult to make it to the regular on-site sessions. And then what evidence-based practice from this study can we share? So we can, based on the finding of this study, we can know that with any woman experiencing pregnancy-related pelvic girdle pain, we should at least give them some education, if not also a personalized exercise program. And the education should go over optimal body mechanics for bending, lifting, sitting, sleeping, and then also some best practice for daily activities with transitional movement. And then if we do exercises, the exercise should focus on breathing, pelvic floor, transverse abdominis, and then hip extensors and abductors. Okay. So then of course, like every study has strengths and limitations. So I think the strength of this study is definitely a randomized control trial. Like I say, has a clear definition of the pregnancy-related pelvic girdle pain, and then you offer interventions through pregnancy to postpartum. And then they do have like very clear, specific, individualized exercises, and then their exercises are designed to try to address the forced closure, which is the assumption of why the pelvic girdle pain occurs during pregnancy. Limitations is definitely a very small sample size, but it is a pilot study, so typically it's expected to be a very small sample size, so they can use these to try to see what they want to do or anything they want to change for their bigger study. And then also what they mentioned in their discussion is there's only a subset of women that is being included due to the inclusion criteria, which is like they only include women at the inclusion, you need to be between 20 to 28 weeks of gestation, which is, they say, it's kind of like a double-edged sword, because it is small, it's narrow for the recruitment, because then you miss anyone before 28 weeks and after 28 weeks. But then also it can be already too difficult for a data analysis purpose, because as we know, 20 weeks gestation and 28 weeks gestation can look very different, but they only compare at that. So if the subject's coming in at 20 weeks, so they compare, and then compare to another one coming in, say at 26 weeks, they compare those data points. They don't take into their gestation age into consideration when they're doing this data analysis. So that can be like a confounding factor that, okay, because 20 weeks and 28 weeks can look very different. So they're saying that they do say with a bigger study, with more subjects, they're hoping to be able to compare the data points at the same gestational age. And then they also said that they use a PGQ, which is a standard one for the pelvic pain, but then they do have items includes like running or carrying heavy objects, which may be difficult for pregnant women in general, with or without pelvic girdle pain. So they do also feel like a research like comparing the score between pregnant women with or without pain of the PGQ score will be helpful to see whether if that is actually, valid for the pregnant patients. And then they do say like the interpretation of the result is limited due to a lack of true control, meaning that you don't do anything. So with their two groups, they both get some sort of intervention. But they also say that because, it is a problem that they typically, when they have the pain, they want to seek some sort of help. So they don't feel it's ethical to actually have a true control, which is like you just don't do anything. But that can be a limitation of this data analysis. So basically, next thought of ideas for the future studies of obviously definitely need a larger sample size to have a stronger statistical conclusion. So then the result can be more applicable. And then with one of the main complaints for the dropouts for the exercise group is the difficulty of getting to the on-site appointment. So then it is worth exploring the feasibility of a virtual sessions with exercise and education. And so the outcomes, practice change that can be, influenced by the study is again that any pregnant woman with pelvic girdle pain should be encouraged to attend at least one education session covering body mechanics for bending, lifting, sitting, sleeping, and the ways of perform daily activities. And that's it. All right, so any questions, thoughts?
Hi, Ingrid, this is Karen. I just have a quick question. Can you hear me?
Yes.
Okay. In your research, did you notice if you found any other research talking about the differences if women had their first or second or so on, like different, like, more kids than just one if it's their first pregnancy, their second?
Right.
Was there a difference?
It can be very different. So some people have it like with the first one and now with the second one, vice versa. The high risk or the risk factor that they put is, history of previous pregnancy. So it is like in the research, it does show that it is probably more often, with, when you have a second, third pregnancy. And then if you have already any previous also orthopedic dysfunctions, like, you already have any hip or lower back, any problems, and if you have a history of trauma, or if you have hypermobility already, like before you get pregnant, because then, with pregnancy, you can just get even more loose. And then if they have increased BMI, or if they're smoking, yeah, those are the main risk factors.
But then
Ingrid,
Yeah,
Yeah.
I did. Thank you.
And this is Marilyn. So in this study, we don't know if the, 12 participants, if this was a first or second pregnancy for them. It sounds like that wasn't like an exclusion or an inclusion criteria, whether it was a first or second pregnancy.
That's not the criteria. So
Right.
they can be, and I don't see anywhere that they kind of say how many they are, the first or second or third.
Because I would think that could, potentially impact results, because I don't know, maybe if more people in one group, it was a second pregnancy, is then that pain harder to resolve? Or if it's a first pregnancy, are they having better outcomes just because it was just the first pregnancy rather than a second? I don't know. I feel like it could have maybe impacted results.
Yeah, I definitely agree. But then with already a small group of subjects, I guess they can. It doesn't really make any sense for them to do these kind of like,
Exclude.
more like,
Yeah.
And they didn't say that whether any, whether it's their first pregnancy or second pregnancy or anything. They just have like, when they're at inclusion, what their gestational age is or gestational weeks. So it's
Yeah.
I have a question, or you have a comment?
Well, I was sort of thinking along the lines of, I think that it may be a confounder to maybe the levels of their pain or the way they're experiencing the pain. However, the behavioral interventions will be appropriate despite previous pregnancies, and the ways that they move through their functional activities, I think is going to be globally applied through those patients in a very beneficial way. And I took note of like they want a strict control of patients who do nothing, but I can tell you, I mean, you can't assume in research ever, but like if you do nothing, these patients aren't gonna necessarily. I've seldomly seen spontaneous pain resolve throughout as the pregnancy continues. So
To back up to the prior question.
here, come over here, Kevin, so people can hear you. Kevin's coming to say something.
So to back up to the prior question about multiple pregnancies and the effects, has anyone noticed treating patients in your personal experience that there's an increased prevalence with increased number of pregnancies, or do you think that that is an influence in terms of the severity of pain or the incidence of pain that you or Ingrid or anyone else who's worked with a lot of pregnant patients may have seen?
I would also say that perhaps how quickly the pregnancies occur back to back may have something to do with it. However, also you've seen patients who had really bad back pain in their first pregnancy, but they were fine the second pregnancy. I've seen that as well.
Yeah.
So I don't think it's like a direct correlation. I think every pregnancy in itself is different with different confounding factors.
Yeah, I see patient. I mean, I do have one that has a pain in the first pregnancy, and then she's in a second pregnancy now, and her pain is worse. But then I also have had patients that has pain with the first pregnancy, but nothing with the second pregnancy. So,
But I think overall, as a population, like if you look at pregnant patients as a whole, if they're relatively sedentary people, and then so like between their pregnancies, if they did nothing to work on their core musculature, those muscles get laxer and laxer, or at least that's what I've observed with, patients who have had 2, 3, 4, 5, 6, multiple children. It seems that it gets laxer as time goes on. So I think it might have more to do with maybe their activity level and also their education level, because some women know they need to work on their core after they deliver and some women don't. So it kind of leads into this in-service, the education piece, and them understanding what they need to do between pregnancies.
yeah, I think that's definitely important, and it definitely like can be a factor. There's nothing in the literature like stating that is a risk factor, but then they only say it's like is history of previous pregnancies. They didn't specify that what they do between the pregnancy. But it makes sense that if they don't do anything and just get weaker and weaker, but if they do something in between the pregnancy, the next pregnancy might be better.
I'll refer you to my last journal club for more information on that topic. Here's a YouTube video.
Thanks,
floating
Alicia.
around.
Thanks. Well, I just wanted to comment, Ingrid, this is Cindy, that you did a great job really summarizing the article and making it understandable for all of us. So I really appreciate that. I did have a question about the education that the patients receive like through this article. Did they, because I might have missed that part, did they specify, to the reader of the article what interventions, the educational like specifically, or just kind of this is the education we focused on, lifting, bending, etc.?
They didn't. That was my question too. That was something I really want to know what they actually teach. But no, they have a good like the exercise program, but then with the education, they just more in general, they're just saying that is a specific to pregnancy that covers body mechanics for those things. But then I can't find anything that more specific than that.
Okay, so for the education piece that we would provide our patients, it would be something that we come up with as a team, right?
Yes.
Okay.
It is. I don't think they have any like statistical like power or anything. But then if you look at their result, the pen graph, it is interesting that the group of people in the education exercise, their pen level do start higher than the education alone. So that might be one of that could be something that makes a difference, because they do, at least from the graph, they do look significantly higher. So that might mean that adding an exercise is still better than just education alone, because the education group the pen like somehow in their study, the group with just education alone, their pen start low already.
Yeah, that's true, because at best they had 0.
Yeah.
Right? They were at 0.
Yeah, at best they're always at best is 0, but then with the education exercise group, at best is still 3. It's like 3 and below, but still there's some pen.
Yeah, I think the results overall, you should just be careful because it was only 7 participants who completed, right? So
yeah.
yeah.
All right, any other questions, or we're gonna?
I know there's only 1 minute left. I was just wondering, how do you guys take attendance? Because for part of the journal club is to take attendance for what you present. So when you guys are sharing computer, did you guys have like a sign-in at the start? I don't know what happened.
Allison emailed me and said that Allie emailed me and said her and Bernice are sharing a computer, and then I don't think anyone else is sharing a computer.
Maybe
Karen and I
Yes.
are sharing a computer
Oh,
at
yeah.
Providence. Marilyn and Karen are sharing a computer.
Wrote down the names that are on the screen here. So
I
I
think
just got the names that are showing.
what you guys can do just to take attendance really easily is everybody just put their name in the chat. So
Okay.
Marilyn, you would write your name, but you'd also write Karen's name in, and then Bernice and Allison. So that way that's a record in the chat. And then, still write it on a piece of paper or whatever to turn it in, but have that as a record for attendance.
Okay. Thanks, Cindy.
Yeah.
All right, guys, thanks so much. I'll try to shove this onto a YouTube video to share with those who couldn't come. And if you want to review later. Thank you. I'm going to stop recording.
Thank you.
Thank you.
Yeah, thank you. Good job, Ingrid.
Thank you.
I like the